morning, everybody. Welcome to this Gise Young Clinical Corner. I am Giulia Masiero from Padova, and I will host this session on a really intriguing topic on an SCS case with some ambiguous findings at the coronary angiography. I am honored to have been joined by Francesco Bruno from Torino, our case presenter, and by Professor Rocco Vergallo from Genova, our expert, who will help us to deep dive into the topic. And feel free to ask many questions by typing it in the chat or raising your hands after the case presented. So I leave the stage to Francesco.
Okay, thank you, Giulia. I'm honored to present this second case of the clinical corner with Rocco Vergallo as an expert. I will share the screen. Just confirming that you are seeing the slide.
Yeah, we are seeing it.
Okay, nice. So let's jump to the case. It's a very provocative case, and we will discuss it later. It's a 65-year-old male with a lot of risk factor, including current smoker, 15 cigarettes per day, dyslipidemia, and arterial hypertension. Not big comorbidities except from focal cryptogenetic epilepsy. And he has no previous cardiac history. And in the last month, he has some episodes of chest pain at moderate effort. And one night, he suddenly developed chest pain and he's been at rest, and he accessed in the emergency department of our hospital. So blood pressure is good, it's 200 over 180, 110 in the emergency department. SAT is good. Hemoglobin and creatinine are good, a slightly elevated BNP of 2015. And the troponin, the first one was 100, is high sensitivity troponin, 100, 543, and 2173, the third troponin. At the echo, he had 50% of left ventricular ejection fraction with a mild hypokinesia in the apical and the anterolateral wall. This is his baseline electrocardiogram. As we can see, there is a T wave, a negative T wave, or is a biphasic T wave in the anterior leads, expecting for a balance pattern. So the patient is an end-stage SCS with a low grade score of around 125. And we decided to schedule the patient for a coronary angiogram in the morning. It was around 3 a.m. in the morning, and we scheduled the day after. So this is his baseline coronary angiogram. As we can see, the right coronary artery has just a mild disease at the mid part and some disease in the distal part. And going to the left side, we can see an unobstructed left main, some disease in the left circumflex, and intermediate stenosis of the proximal LAD in bifurcation with diagonal. And we can see also some signs of heaviness in lesion. So what to do? This is a 65-year-old patient with a high burden of cardiovascular risk factors and end-stage ACS without a clear culprit lesion, but with an intermediate stenosis of the proximal LAD with elevated troponin and ECG and echo abnormalities for anterior ischemia. So we decided to do an OCT run, and we expected to find a ruptured crack in the proximal LAD. Just before going to the OCT run, I will show you the co-registration with high flow injection. So if we stop here, we can see that the intermediate stenosis of the proximal LAD as a there is a intermediate stenosis in the proximal LAD. And we can see also there is some haziness here in the left main that we didn't see from the diagnostic angiogram. So going to the OCT run, here we are. This is the Ultron 2.0 console from Abbott with the aid of artificial intelligence. So we can see here we are in the left main. I will go slowly in the run. So here we are in the left main. There is an unobstructed left main with some plaque here. And at this time here, we see clearly a rupture plaque in the left main, as we can see here, without thrombus and with already some radialization progress. If we go further, so we see here there is some plaque in the LAD. Okay, here there is some plaque in the LAD, and then we go to our intermediate stenosis. That is a highly lipidic stenosis, as we can see here, just at the level of the carina with the diagonal of the bifurcation. And the plaque, as we can see here, is a highly lipidic plaque with macrophage and also thin calf fibroateroma. So I will give the word to Rocco Vergallo if we have some comments of the OCT run. Unfortunately, from the PowerPoint, the quality of the image is less than the console.
Yeah, but Francesco, the quality is actually very good. We can see clearly. So good morning, everybody, first of all. And Francesco and all, I think this is a case where really is a paradigmatic case showing the real utility of imaging in the context of non-obstructive coronary artery disease in patients with myocardial infarction. So is a patient with a young patient at high risk with multiple cardiovascular risk factors who benefit from intravascular imaging, because coronary angiography shows some disease, I would say intermediate disease of the proximal LAD and distal left main with some haziness. So basically, without imaging here, we cannot clearly understand the culprit of this myocardial infarction. The OCT is very nice, the OCT pullback, and I would add that if you can go on the distal left main on the ulcerated plaque, I think this is a really nice image because it clearly shows a lipid-rich plaque that you can see with appearing with the low signal with diffuse borders plaque with a small ulceration. It's true, it's not that large as we can see usually, but is in the distal left main at the polygon of confluence just before the bifurcation. I would say that this plaque rupture is at least subacute. I think we all can agree on this because it's true that there is no thrombus, but if you look at the cavity of this plaque, is irregular. It has some irregularities, which usually you can see in the acute subacute disruption. So definitely could be the culprit of this ACS. If you can go on the LAD, here also you have a lipid-rich plaque with some thin fibrous cap. And you have clearly shown some areas with the bright spots and backward shadowing, which are suggestive of what at OCT you define macrophages. I mean, I'm always very cautious on macrophages. In particular, I don't care about macrophages during my clinical practice. Of course, is a good research tool. And but we know there is some trial ongoing also focusing on the presence of macrophages. But I usually recommend to be cautious on this feature because it can be affected by several microstructures of the coronary plaque. But definitely this is a plaque with a large burden, although we cannot measure plaque burden by OCT, which is lipid rich at high risk. I don't know if everybody agree or if someone has different opinions. These slides summarize the findings. So we have the plaque rupture on the polygon of confluence of the left main without thrombus and with a large MLA. On the middle AD, a lipid-rich plaque with thin fibrous cap, so a thin cap fibroateroma with some spots suggestive of macrophages. And the MLA is 4.4 millimeters square in the LAD, which is something that is borderline, I think higher than borderline. The few data we have on the comparison between OCT and FFR shows that an MLA of 3.1, 3.5 can predict some hemodynamically significant stenosis. But here we are focusing on the plaque characteristics. So this is an additional data, of course, important, and MLA was 4.4 millimeters square. So
yeah. We have two high-risk plaques. Maybe one, it is the culprit. They are both non-flow limiting. And so, Francesco, how do you treat?
Yeah, so now we have to decide what to do, because we have an high-risk plaque, an ulcerated plaque in the left main with a huge MLA, and the high-risk plaque in a young patient that actually is prone to plaque instabilization, because what is happened to the left main can happen every time to the LAD. So here the question is, what's next? So to stent or not to stent? That is the question. And to stent what? To stent the LAD or to stent the left main? So after lots of discussion in the cath lab, we decided to do a conservative treatment in the left main and the PCI to the proximal LAD. So we started a kangaroo infusion. We did a predilatation with a 4 balloon guided with the OCT finding. And we stent with a Megatron 4.518 at 16 atmosphere, which actually is a 4.745 of diameter. This was guided by the EL to EL diameter by OCT. We did a pot with a 5 balloon and then a recrossing and a kissing balloon to the diagonal. And the final pot with a 5 NC. This is the final angiographic result. And for first matter of time, I will switch to the final OCT. As we can see here, this is the review mode of Ultron 2.0. Here we can see a perfectly opposed stent and a very well expanded here. We already see that everything is gray and there's nothing red or yellow. So the apposition is perfect, and also we don't have any edged section, as we can see here. So the flow in the diagonal is good and the flow distally is good. So now we have done almost 50% of our job, we believe, in these patients, because we did the PCI, but we have to take in mind that the optimal medical therapy is the most important part in this patient. So into hospital was without any complication. LDL was actually 140 with elevated CRP and neutrophil lymphocyte ratio, so a very high risk patient. We did a counseling for smoking cessation, and the patient was discharged after 3 days with a normal ECG. With a very aggressive medical therapy, aspirin, ticagrelor 90 milligram bid for 12 months, beta blocker, RAS, and calcium antagonist for hypertension and cardiac remodeling. And we started patient on rosuvastatin 20, ezetimibe 10, and already CCK inhibitor alirocumab 150 milligram in fast track. So we plan to do an angio control at 6 months. Actually, it was January, so we are going to do an angio control in the next month. I called the patient yesterday, and it's fine. It's asymptomatic and very fine. So before switching to the discussion, we have to introduce the new trial that was presented last week, the ACC 24. That is the PREVENT trial. The PREVENT trial is one of the first trial after the small prospect absorb, in which we try to find if there is a role of preventive PCI against medical therapy alone for treatment of vulnerable atherosclerotic coronary plaque. So briefly, this was in this trial, the authors randomized 1,606 patients with coronary stenosis more than 50%, but with negative FFR, so FFR more than 0.80. These were mostly chronic coronary syndrome patients, almost more than 80%, some unstable angina, and around 2% of STEMI patients with non-culprit lesion. And the lesion were deemed to be high risk if 2 of the imaging features at OCT or IBUS with NIRS were found. So MLA less than 4, plaque burden more than 70%, thin calcium fibrosarcoma by OCT or by IBUS, and lipid-rich plaque by NIRS. So the intervention was optimal medical therapy plus preventing PCI. in the intervention arm, and the control arm was optical medical therapy alone. This slide is very nice and is published on EuroPCR by Nazmi Khalik. And the outcome, primary endpoint was target vessel failure, was a composite of cardiovascular death, target vessel MI, ischemia-driven target vessel vascularization, or hospitalization for unstable angina. And we can see there is a significant, statistically significant difference between the two arms, with a 0.4 incidence at 2 years of the endpoint in the intervention arm, so in the PCI arm, and 3.4% of MACE in the control arm. And this difference remains statistically significant also after 7 years, with a median follow-up of 4.3 years. So the author conclude that in patients with non-flow limiting and vulnerable plaque, preventing PCI with optical medical therapy lead to fewer MACE compared to optical medical therapy alone. However, and I will ask to Professor Rocco Vergallo his opinion of this trial and also the limitation.
Okay, so Francesco, please call me Rocco Vergallo. So please remain on this slide, which show the first finding of this study. I mean, it's not easy to find and to analyze and to detect vulnerable plaque by imaging. If you look at the OCT image that this author selected to prepare this slide, not you, but the colleague, this is not an image of TICFA, but it's just calcium with the thin fibrous cap. So a very stable plaque, actually. So if you can go to the next slide. Okay, so I think this slide, before going to the discussion, which is the most important part, and to your question, I think this trial has been shown and discussed on several social networks also as a positive trial. I don't think it's so. So first of all, if you look at this statistical analysis, the event rate was much lower than expected, and then calculated at the time of power calculation. So is a study clearly underpowered to detect a significant difference in outcome. And if you look at the outcome, the absolute difference is 3%, but most of event, 2.3% of this difference is actually explained by ischemia-driven target lesion revascularization. So if we want to prevent with stenting of non-flow limiting vulnerable plaque, we need to prevent hard events, so cardiac death and myocardial infarction, which were not different between these two groups. So I think this study is a negative study for me. Several findings important to me and useful for the discussion are that stable angina patients were more than 80%. Patients were really low risk from a coronary point of view, because almost half patients were single vessel disease patients. And yes, I think this trial should let us think about the concept of vulnerable plaque, but definitely doesn't show that stenting vulnerable plaque is a useful thing on top of aggressive medical therapy. So go to the last slides. These are my take-home messages, which are shared also by Francesco. In ACS, without a clear culprit and myocardial obstruction with non-obstructive coronary artery disease, definitely intracoronary imaging helps to make diagnosis and to guide treatment. OCT in this case, in my opinion, is preferred because look at better at the micro features of plaques. Aggressive optical medical therapy, including the potent lipid-lowering therapies, is the treatment of choice for vulnerable plaques so far. We don't have enough data. PREVENT study is not enough to tell us that we need to stent non-flow limiting vulnerable plaques. So, and I would open the discussion. Giulia, if you can moderate the discussion, please.
Thank you, Rocco and Francesco, for this wonderful presentation and comments. So first of all, we talk about the case. What do you think, Rocco, about the practical treatments of these two different high-risk plaques?
So I will be honest. Francesco did a great job, and actually the follow-up is giving, is favoring his choice because the patient went good and is going good. But usually when I find a plaque rupture, even a small plaque rupture, I tend to stent. Of course, here there was a huge MLA and was a left main, but probably I would have stented, but I'm not saying that is the right choice. I agree with the choice of stenting that vulnerable plaque beyond the value of the plaque features that he analyzed, because this it's true that it was a 4.4 millimeter square area, but it was in the context of a very large LAD. So we had a almost significant plaque in a large LAD. So I would have stented too.
Maybe Fabrizio want to add something.
No, thanks a lot. Thanks. I think that Francesco presented a great case. Thanks, Rocco. But I think that we had some. I know this about the plaque on the left main. This is just anecdotal because there is no clear evidence. We have some patients which we didn't treat, and with a positive follow-up with our current events with a plaque rupture on the left main without critical stenosis. Of course, small plaque rupture without thrombus. And we put them on the long-term dual antiplatelet therapy. The other stuff that I always think when I see these patients at how many patients on whom we do not perform OCT have a small plaque rupture on the left main. We don't know, we don't treat them, we put them on dual antiplatelet therapy, and this is enough. This is my other point of view. But of course, as Rocco correctly said, it's just I think it's just a matter of opinion and a particularity of the stenting on the left main. What do you think?
Yeah, I completely agree, Fabrizio. I mean, I have left some of these plaques in the distal RCA. I remember one case which got completely healed at 1 year follow-up, completely sealed ulceration like that. And I completely agree with you. There is no right response to this question. So just I feel that in the left main, I would have had some problem to leave it, but I mean, you so far you are right, because the patient is going well, and I'm sure that the follow-up will show stable plaque on the left main, and I would be curious to see the follow-up OCT of this patient. So definitely you did the right choice.
Thank you.
I think that nothing will. I don't know what will happen. Maybe we will find again the same lesion. What do you think? It's very difficult to predict what we will find if we would perform OCT again.
So in my experience analyzing serial imaging, a lot of serial imaging, these kind of plaques in most cases don't completely heal, so they are not replaced by new tissue inside. Sometimes it happens, but I would expect that this plaque will become smoother in its cavity with the increase in thickness of the fibrous cap. So it will stabilize like this, remaining like a small ulceration, stable, smooth, and without any clinical significance. I would expect.
Yeah. I would like also to read your editorial in European Journal now of the RCT of Impella.
Yeah, I wrote. So actually, I am going to submit today. I will.
I'm very curious about this.
Yes. Yeah, a different topic, but very nice. Yeah.
Thank you.
Thank you. Moving to question. In the PREVENT trial, the vast majority of patients have been evaluated with IVUS. But in this case, you use OCT or IVUS?
Yes, this is another a great question, and another I think drawback of the PREVENT trial. So they used IVUS, I think in 95% of patients. In some patients was radiofrequency IVUS, and in some other patients it was associated with the NIRS. But it's paradigmatic. It is, I think, very important that all just 5% of patients were analyzed by OCT, which I think is the only imaging modality that can detect thin cap fibroateroma, because the definition by virtual histology IVUS is a kind of, I mean, nonsense to me, because you cannot really detect the fibrous cap. So I think if you want to detect vulnerable plaques and vulnerable plaque features, you need to use OCT. IVUS, of course, is the best imaging modality to look at plaque burden, which is I think so far the most important vulnerable feature shown in randomized trial, in imaging trial, like in the prospect. So I think a combination of the methodics is good. If you have IVUS, you should look at plaque burden mainly. But even with the new IVUS generation, high resolution, you are not confident to define the thin cap fibroateroma. You can tell that there are lipid plaque for sure. With NIRS, you can tell it even more confidently, but you cannot define a thin cap fibroateroma by IVUS.
Okay, talking to plaque rupture, and people ask which evidence strongly recommend you to treat plaque rupture? Which RCTs or strong studies?
There are no randomized controlled trial, but on this. But I mean, it's the plaque rupture is a plaque that has no preserved vessel structure, and I mean, I feel more confident to leave some erosion because it has a preserved vessel wall, and you have just thrombus and some endothelium, which is damaged. So in that case, I feel more confident to leave the plaque untreated if it doesn't affect the lumen. In case of rupture, I mean, there is sometimes this was a small rupture, but when you have a large rupture with some content inside, that is highly thrombogenic. So I don't feel confident, but definitely we don't have a trial specific on this, randomized to stent or not to stent rupture. But I mean, usually these kind of plaques are those that are subocclusive or occluded in the context of myocardial infarction.
So this is no-flow limiting stenosis, really mild stenosis. So
yeah,
now
this is a really mild stenosis. So on these lesions, we don't have data. The only data that we have is on the conservative treatment of erosion, and also those are not randomized. So we need randomized trial.
Thank you. And moving to high-risk plaque, stable plaque or vulnerable plaque.
Yeah.
Do you agree with the prevented definition of these vulnerable plaque features?
I mean, all these vulnerable plaque features are good, taken one by one, because the IVUS definition is taken from the prospect. So I think plaque burden by itself is probably the strongest vulnerable plaque feature. Also because I mean, we don't have to forget that about 40% of ACS are caused not by plaque rupture, which is, I mean, precursor is a thin cap fibroateroma, but by plaque erosion, which actually has another kind of phenotype underlying. We usually are more fibrous plaques and something like that. So I think we need to start from this assumption. So if we consider just ruptured plaque, yes, these are good parameters of vulnerability, because the IVUS one are taken from the prospect. So thin cap fibroateroma defined by IVUS, plaque burden and MLA. There is the IVUS NIRS definition of vulnerable plaque, which also has been shown to correlate with the poor outcome in previous studies. And the OCT one, I agree with choosing the thin cap fibroateroma without adding anything else like macrophages, which in my opinion are weak predictors because of their variability in interpretation and analysis.
Thank you. And do you think there is role or there will be a role for drug coating balloons in the treatment of these lesions?
I don't know. I have reviewed a paper on this, so there is already research on this. A paper I think got accepted finally, just not published. treating vulnerable plaque defined by OCT or NIRS with drug coated balloon. In my opinion, when you have this kind of plaques, if you balloon, even if you use drug coated balloon, you are activating those plaques. Because when you do balloon angioplasty, you always can see, even if you perform OCT or IRUS afterwards, some disruptions on and the dissection of plaques. If you are ballooning those plaques, I think you are again reactivating those plaques, and I'm not sure is a good option in this kind of anatomy. I prefer using drug coated balloon on more fibrous plaques, but totally, I mean, without we don't have evidence, you know.
We have also to remember that we have strong evidence with PCK inhibitors of
Exactly.
PCFA remodeling with the Pacman trial, with the Pacman study and the other study.
Exactly. So I completely agree with you. We need to put these thoughts into the context of a very effective medical therapy nowadays, because the potent lipid lowering therapies we know that stabilize these plaques. If you look at these plaques 6 months later, the fibroscape is increased, the lipid pool is reduced. So I mean, we always need to think to this. So we are talking about non-flow limiting lesions, of course.
Yeah. So you have used OCT for the plaque evaluation, also the plaque treatment with DES. Do you use also OCT or only angio or CT scan for follow-up?
Yes, I use, I have a very good cardiovascular radiologist in Genoa now, and we work closely. So I like to control patients. I like very much non-invasive imaging, to be honest, and I think that will be the future. I mean, a CT scan with the photon counting arriving is becoming so good at looking plaque features, which I mean are not focal, we know, but diffuse in nature. So with TAC, the advantage is that you can look at the plaque, but fortunately, you can look at different time points more than invasive coronary angiography. So you can have not just a snapshot of the plaque features, but you can have another important information, which is the plaque activity. You know how the plaque are progressing in one patient. And I mean, you can get so many information like inflammation in pericoronary adipose tissues. So I like non-invasive imaging, and I often control my patient with CT angio if I have some doubts, without bringing it to the cath lab.
Thank you very much. So time is running out, and I really want to thank you, Francesco. Thank you, Rocco, for your case, for your discussion, for your insights. It was really, really interesting. Thank you a lot.
Thank you, Julia. Thank you all.
Thank you
very much.
everybody.